very much for that introduction, Yvonne. My name is Nicola Mason, and what I'm going to do is show you some of the data that we've been generating in dogs with spontaneous HER2-positive bone cancer. We're really looking at the vaccine that Yvonne has just described to you and looking at its capabilities of preventing metastatic disease in this spontaneous large animal model. So a quick recap of why we're using dogs. What's this all about? So when we look at dogs are genetically similar to us. So there are orthologs for about 18,000 plus of the 24,000 annotated human genes. And if you actually look at the human genetics, twice as much human sequence aligns to dog sequences as it does to mouse sequences. So whether we like it or not, we're actually more similar to dogs than we are to mice. Importantly for this, dogs share our environment. I'm not talking about research dogs, beagles. I'm talking about our pets. They walk with us, they eat our same food, they're in our same environment. So obviously, both genetic and environmental influences on tumor initiation and progression are experienced by the same species. So we really feel that the dog, client-owned, privately owned dogs, are a good model for being able to evaluate certain therapies. Dogs develop spontaneous cancers, and they've developed spontaneous cancers with human relevance. And you can see them listed there: non-Hodgkin's lymphoma, osteosarcoma, melanoma. Dogs develop breast cancer and soft tissue sarcomas as well. And these cancers have similar histologies, biological behavior, in some cases genetics, and therapeutic responses. Certainly in the clinic, I'm a veterinarian, we treat dogs with very similar therapies to how we treat people. And when we look at cancer that develops in dogs, unlike mouse models, or the majority of mouse models, these tumors develop over periods of time. They're developing in what we believe are immune-competent individuals. So particularly when we're looking at immunotherapy, these tumors are subject to immune editing. They're subject to immune escape. Provide a very important model for us to evaluate these immune therapies. And also we recognize tumors recurring in dogs after standard therapies like surgery, radiation therapy, and chemotherapy. We recognize chemoresistance, and we recognize metastatic disease that goes to classic sites such as lymph nodes and lung. Also, there's an awful lot of dogs out there, 75 million in the States, 4 million of them are thought to go on and develop cancer. And they have been used and are increasingly recognized as being a good model to evaluate novel drugs, safety, toxicity, PK/PD, therapeutic responses, and also evidence of biomarker assessment. So why are we not using breast cancer? I should probably address that first. And the simple reason for that is, at least in the States, we don't see an awful lot of mammary cancer in dogs. And the reason for that is that most of these dogs are spayed. And that drastically reduces the incidence of breast cancer. So we simply don't see many dogs with breast cancer. If you go to Europe, you will see more of them. And most of the studies on mammary carcinoma in dogs are from the Europeans. So we have chosen a different HER2-positive tumor to determine whether this vaccine can prevent metastatic disease. So I'm just going to give you one slide introduction to bone cancer, because obviously that's a bit different. It's a highly aggressive mesenchymal tumor of the bone. And it occurs in children. It affects about 400 kids a year, and you can see that they develop these, I haven't got a pointer here, they develop these large swellings in the appendicular skeleton that are characterized radiographically by a lot of proliferation as well as lysis. And the treatment for osteosarcoma in kids is actually neoadjuvant chemotherapy, thanks very much, neoadjuvant chemotherapy followed by limb-sparing surgery or amputation, which is quite dramatic if you're a child of 10 or 20 years of age. And unfortunately, about 30% of these kids will go on to develop metastatic disease. And unfortunately, there is no treatment for metastatic osteosarcoma in kids. When we look at the dogs, the model there really does phenocopy that in humans. We see our large and giant breed dogs developing osteosarcoma, just like the kids. They have large swellings in certain areas of the bone. They are also lytic and proliferative. We treat our dogs in the same way. We do limb spare, or we do amputation of the affected leg. Unfortunately, however, about 90% of our dogs will go on to die of metastatic disease. We know that it's inevitable. So therefore, we have a good model for us to determine whether we can prevent metastatic disease. So the median survival with amputation and chemotherapy is about 300 days. So we can very quickly determine whether this vaccine is going to prevent metastatic disease. And this is just some data from Chankana and Melissa Paoloni, gene expression profiling, and actually in the blue are dogs' tumours, and in the red are children's tumours. And you really can't separate them out at the level of gene expression. So these really are good models. Osteosarcoma expresses HER2/neu. It expresses it in kids and it expresses it in dogs. When you actually look at the expression, it is mostly cytoplasmic, less so membranous, which has, again, been documented both in pediatric as well as canine osteosarcoma. Here's data. You can see the staining here in two different primary bone tumours from dogs. Here's an H&E and HER2 staining from our lab. And when we look at the staining, we see in osteosarcoma that there's a lot of intratumoral heterogeneity. So some areas are positive, some areas are not. And again, this just outlines or depicts this concept of mainly cytoplasmic expression compared to carcinomas like breast, and in this case transitional cell, where HER2 is much more membranous. And then we have a Western blot here demonstrating expression in certain dogs, and expression in obviously the mammary carcinoma cell line and a canine mammary carcinoma cell line. And we do see expression in the myocardium. It's not well depicted here, but it is, has been described in the literature that cardiac or myocardium expresses HER2/neu in the dogs. So interestingly, trastuzumab, a monoclonal against HER2/neu, has been tried in kids with osteosarcoma. It doesn't seem to work. But of course, with this HER2 molecule being expressed in the cytoplasm, it's a target for T-cell mediated therapies. So Yvonne's already described this technology. I don't need to go through this. This is a similar study, again, out of Yvonne's lab, demonstrating that utilizing this ADXS31164, this Listeria targeting HER2, you can effectively prevent metastatic disease following injection of a low HER2 expressing mammary tumor cell line. When we actually look at the homology or identity between canine HER2/neu and human HER2/neu, it is highly similar. And if we just pick out those domains that Yvonne was talking about in the vector, you can see we're looking at 89% in the extracellular 1 and 93% in the extracellular 2 domain. And when we get to that domain that encompasses the tyrosine kinase domain, the intracellular 1, that is 98% identical between human and canine. So this is our trial. We wanted to perform a phase 1 trial to evaluate whether this vaccine is safe and can prevent, again, inevitable metastatic disease in a HER2-positive tumor, which is osteosarcoma. So the clients would come in, we would diagnose their dogs with osteosarcoma. They would undergo standard of care treatment, which is amputation and 4 doses of carboplatin. We avoided the use of adriamycin because of the potential synergy with a HER2-targeted agent. Then we would screen the dogs 3 weeks after they'd received this treatment to determine, one, whether they had metastatic lung disease. If they already had metastatic lung disease that was grossly evident by radiographs, they were not eligible for the study. They had to be healthy in all other respects, and they had full cardiac assessment, including troponin levels and echocardiogram, to make sure that they were functionally stable with respect to their cardiac function. We then vaccinated them 3 times, 3 weeks apart, and then followed them up every 2 months. We were looking mostly for safety, but also looking at evaluation of HER2-positive immune responses, disease-free interval, and overall survival. So these are our 18 dogs, a 3+3 study, group 1, 2, 3, and 4. Large breed dogs, middle age, fairly standard. And then all of them had to be HER2-positive in the primary tumor that was removed, and that's the score that we see there. We have the doses ranging from 2 times 10 to the 8 colony-forming units going up to 3.3 times 10 to the 9 colony-forming units. And then we did have a compassionate care group that had metastatic disease following amputation and chemotherapy. So what happens when you administer live recombinant Listeria intravenously to the dogs? We do see some side effects, but they are mild and they are transient, and rather similar to the side effects that are seen in humans that have received the HPV targeted vaccine that Yvonne has spoken about. So some of these dogs will develop pyrexia, some nausea and vomiting, small numbers, and all these are mild and again transient, basically occurring around about 2 to 4 hours after administration of the vaccine. We saw a couple of dogs developing mild arrhythmias, ventricular premature contractions that we think are associated with cytokine release, again early on, and these resolved. We've seen some mild thrombocytopenias, and we've seen mild increases in liver values, again, that resolve by after 1 week of administration. And this is not surprising because Listeria is hepatotropic, so we expect to see some degree of liver inflammation. These are our temperatures here. We have the different dose groups here. This is timing, and you can see in each group, we see by 4 hours the temperature has in fact increased, and then it comes down again. So these are mild temperature increases and no change in blood pressure. So we're not seeing any dose-limiting hypo or hypertension. This is quite interesting. It's a bit small, but this is basically looking at the inflammatory response to the basically hematological parameters 24 hours after we've administered the HER2 targeting vaccine. And so at the top here, you can see the different parameters we're looking at, white blood cell counts and neutrophils and so on. And these are the doses here. So you can see in each dose group, 24 hours later, we see an increase in the white blood cell count, an increase in the neutrophil count, and a decrease in the platelet count at 24 hours. And if we look at this second row here, when we look at the doses, again on the side, and the percent increase in white blood cells, it really doesn't matter what dose you give, you still see some degree of increase. It doesn't seem to be dose dependent. But what was really interesting is when we actually divided the dogs out into those dogs that lived and those dogs that died from metastatic osteosarcoma, you can see that there is a statistically significant difference in the inflammatory response that is produced in those dogs. In other words, at 24 hours, you can predict who is going to live and who is going to die based on their increases in white blood cell count and neutrophils, which is really quite interesting. Obviously, this is a very small group of dogs and it needs to be expanded out, but that gives some credence to the concept that certainly the inflammatory response that's induced by the Listeria may be very important here. This is a really busy slide, so I'm going to sort of hone it down a little bit. This is what we were looking at to determine whether this vaccine was capable of breaking tolerance to HER2/neu. And so our dogs are down the side here, and these are the various time points along the top. This is an interferon gamma ELISpot analysis asking the question, do the dogs generate immunological responses, interferon gamma production in response to overlapping peptides of EC1, EC2, and IC1. And I think based on the fact that IC1 is 98% conserved, let's just focus on this particular column here. So you can see when our dogs are coming in, very few of them, only one of them that actually had a concurrent nephroblastoma, have immunological responses against IC1. They shouldn't. It's their own protein, essentially. They shouldn't do that. But at 3 weeks after the vaccine, we start to see some dogs developing immunological responses against the IC1 domain. That's 3 weeks after the last in the initial series of vaccines. But what's also interesting is when we look at 2 months and 4 months and 6 months, we start to see dogs developing late immunological responses against HER2, as you can see here and here. And again, in 4 months, you can see some of them developing really robust interferon gamma responses against HER2/neu. And what's interesting here is that these dogs have seen no other HER2 other than their vaccine. So we're either looking at a delayed response to the vaccine, or we're looking at expansion of HER2-positive T cells in response to something, and that possibility is recurrence of HER2-positive disease. And when you actually look at the timing here, this is about 8 to 10 months after these dogs were originally diagnosed, and that is the time that these dogs are starting to develop metastatic disease. So certainly from a temporal standpoint, this would fit with perhaps recurrence of HER2-positive disease and subsequent expansion. When we look at a small group of dogs who arrived with metastatic disease, however, that had not been vaccinated, so just after amputation and chemotherapy, we only saw one of those dogs having a response to IC1. So in other words, having metastatic disease alone does not break tolerance to HER2. It appears that you have to be primed with this vaccine before you can generate that immunological response. Also, we have some dogs, I don't think it's shown up very well here, we have some dogs that actually develop very robust responses at the time that they were found to actually have relapsed with disease. And this chap right out here at 2.5 years, developing a very robust response as his bone isoenzyme increased. We looked at cardiac parameters over 2.5 years, and we see no change in cardiac troponin levels and in echocardiographic parameters. So we can break tolerance to HER2/neu, but we don't seem to cause any problems with dilated cardiomyopathy. And when we actually look at the survival curves here, again, this is a phase 1 study, so there's no control group, and we are looking at a very small number of dogs. But as a veterinarian, I can tell you this is absolutely dramatic. So these are our disease-free intervals and our percent survival here. And if we look at the data from the literature, of which there is much, looking at amputation and carboplatin treatment alone, the historical median disease-free interval is about 100 to 250 days, whereas in these 18 dogs, our median disease-free interval is 615 days. And when we look at median overall survival, 200 to 320 days. In the vaccinated dogs, we're looking at calculated from the Kaplan-Meier product, 956 days. And our 1 year and 2 year survivals really dramatically different from those historical controls. So this is really very exciting, and it suggests that this vaccine can actually prevent metastatic disease in HER2-positive appendicular osteosarcoma. And we're proposing that this occurs through the ability to induce HER2-specific T-cell responses, as well as the ability of this vaccine to induce high levels of IL-12, which can also influence FAS expression on metastatic cells and may actually eliminate them as they are in the lung. I want to just finish with one sort of case that came out of the compassionate care group, because I think this gives us a window into what could be happening here. So this is a dog that arrived after amputation and chemotherapy that actually already had metastatic disease. So there's a small lesion in the right cranial lung lobe. This dog was treated on compassionate care, had 3 doses of vaccine, and after that we saw that this lesion had grown dramatically. So it's a little bit disappointing. But what was interesting is the rest of the lung fields remained clear. Quite unusual. We would expect them to be peppered with metastatic disease. We gave this dog ICG, which is a dye that fluoresces in inflammatory areas, and then actually took the dog to metastatectomy. We were able to see fluorescence in the nodule, but also fluorescence in other areas of what appeared to be normal tissue, normal lung tissue, and that actually came out with the metastatectomy. Here you see the H&E. This is a metastatic lesion here. There's a fibrous capsule and what looks like an inflammatory cell response around that lesion. And when we actually looked in the area of lung that looked normal and appeared normal both on CT and radiographs, we saw multiple foci of inflammation. And when we looked at this, the nodule, stained it for CD3, you can see all these T cells lining up outside this nodule, but very little T cell response within the nodule. Here, in the rest of the lung, in these inflammatory foci, we saw very clear evidence of CD3 positive T cells, and they tended to be, it's a little difficult to see, they tended to be in areas surrounding pleomorphic spindle cells. Now, we can't say that those are osteoblasts. They could be type 2 pneumocytes. It's difficult to say. They stain with vimentin, and they have mitotic figures. So the suggestion here, I think, is that perhaps we can stimulate immunological responses that are effective at eliminating micrometastatic disease responsible for the dog surviving for long periods of time. But if they already have pre-existing disease, perhaps alone we need to do something extra to enable these T cells that are being recruited to the area to infiltrate into the tumor. So in summary, we have acceptable, low-grade and very transient toxicities when we give this vaccine to dogs. When we administer this in the setting of minimal residual disease following removal of the primary HER2-positive tumor, we can actually induce her to specific immune responses that we think are capable of eliminating micrometastatic disease. And perhaps we should be thinking a little bit about combination approaches, perhaps together with chemotherapy or radiation therapy or even CAR T-cell therapy to enable these T-cells to get into that tumor. And this may have wide applicability for the treatment of HER2-positive cancers. And then the development of this, there is actually a conditional license that we hope will be approved for dogs next year. So this will get out onto the market for veterinary usage. Orphan drug approval for this vaccine in pediatric osteosarcoma was achieved in May of 2014. And then the IND, as Yvonne stated, to begin phase 1 clinical trials. And with that, I think Yvonne and I are going to take questions.
So while I know you won't be able to contain your excitement, but that's particularly.
Oh, thank you. That's great.
So I think we'll take one or two burning questions. We'll take those while Tom comes up and gets his slide presentation together. Yes.